Today I'll be talking about the efficacy of adalimumab in the control of pediatric non-infectious uveitis. So some background and rationale. Pediatric non-infectious uveitis is an asymptomatic site-threatening disease. First line of management for it is corticosteroid along with other immunosuppressants like MMF or methotrexate. However, a significant proportion of these patients remain refractory to treatment, and the pro-inflammatory cytokine tumor necrosis factor alpha is thought to play a key role. Adalimumab, a recombinant human immunoglobulin monoclonal antibody that specifically binds to TNF alpha, is the only systemic biological agent currently approved for treatment of non-infectious uveitis. And despite FDA approval, there is a paucity of data on the ocular outcomes in pediatric non-infectious uveitis. So a bit about pediatric non-infectious uveitis, that it does not present like adult uveitis. There is no pain, redness or photophobia usually seen, and these patients then because of this present in an advanced stage when the parents notice some squinting of the eye or some whitish reflex from the eye, and that is why screening is the key in such patients. Corticosteroid use in pediatric population and otherwise also leads to a lot of complications systemically as well as ocular-wise. And to avoid such side effects of corticosteroids, biologicals like adalimumab are the need of the hour. So the objective of my study was to assess long-term control of pediatric non-infectious uveitis by adalimumab, focusing on the change in best-corrected visual acuity and its steroid-sparing effect. Apart from that, to assess the drug retention rate on the basis of rate of discontinuation due to inefficacy, loss of efficacy, side effects, or ocular remission. The materials and method included a study being prospective observational study. Study period was 1.5 years. Our patients were basically refractory pediatric non-infectious uveitis patient on multi-drug regime already and now being started on adalimumab. Sample size was 7 for my study and I have collected data for 10. These were my exclusion criteria. Methodology, visual acuity as well as anterior and posterior segment evaluation of these patients were done, and then these patients were followed up for a duration of 12 months and were monitored every 2 monthly for any flare-up of ocular inflammation, side effects, worsening of ocular morbidity were documented. So terminologies were clearly defined as per Sun classification and other studies on the same topic. For refractive uveitis, active inflammation, inactive inflammation as well as treatment failure. Coming to the demographics, 70% of the population were females and 30% were males. And anatomical classification wise, anterior uveitis predominated our study. When we talk about the etiology, as it is commonly seen in pediatric non-infectious uveitis, GIA was the leading cause of uveitis in our study too. When we see this chart, we can see the response of ocular inflammation to adalimumab when compared to baseline to 12 months. Majority of the patients were having no ocular inflammation at the end of 12 months. This is a chart depicting the visual acuity trends over the 1 year duration of the study, and visual acuity was decently well maintained throughout the period. And if we talk about the mean number of steroidal drops per eye per day, there was 73.3% of patients were off steroidal eye drops after 12 months of use of adalimumab, which was again statistically significant even way before at 6 months and as well as 12 months. When we talk about systemic steroid trend over 1 year, oral steroid 7 out of 8 patients were off systemic steroids too at the end of 1 year, and this was again statistically significant at 6 months as well as 12 months. When we talk about the drug retention rate, none of our patients during the study period reached any treatment failure, and the side effect profile of adalimumab worked in favor of compliance as shown in our study, where 90% of the subjects were compliant to adalimumab. One patient was a drug defaulter because of lack of availability of adalimumab in their place. So the effectiveness of adalimumab was evident as oral steroid-free remission was seen in 87.5% of our patients, and 73% patients were off steroidal eye drops. None of our patients during our study period reached treatment failure. 90% of the subjects were compliant to adalimumab. We compared our study with 2 other studies which were retrospective as well as multi-center studies, and the data was very much comparable. The response to topical steroid eye drop remission was very much comparable. The limitation is limited size of the study, and to conclude, adalimumab is effective in controlling ocular inflammation, delaying treatment failure, and has beneficial steroid sparing effect in cases of pediatric non-infectious uveitis. Thank you.
This was your thesis topic?
Yes, sir.
How sample size was calculated?
So sample size was calculated by seeing the other studies which have been done on this topic particularly, and then calculated by power
in such rare cases, sample size will be very high. Basically, this is non-probability sample. You can't calculate sample size in such a small sample size. Only 7 was calculated.
Yes, sir. But as per the other studies also, because multi-center studies also had cases of 17. So, and since we were having these patients and there was no other studies done in India per se on this topic, that's why it was important.
A rare phenomena, you are selecting some topic which has only 7 the initial calculated sample size, not basically calculate this is non-probability sample, and we have got 10 cases. Another thing is what was the duration of a SWAT when it was labeled as multi-drug resistant?
So, sir, 3 months.
3 months. After 3 months,
Yeah.
it was labeled as
Yeah.
multi-drug.
So these all patients were on methotrexate or MMF along with oral corticosteroid, and topically they were at least on 3 drops per day at 12 weeks. Those were the patients who were selected.
But there is a role, basically topical SWAT has a very limited role, especially in
Yes.
cases of posterior
Yes, sir.
uveitis or
Yes, sir.
panuveitis.
Yes, sir.
There is a role of systemic SWAT or whatever.
Yes, sir. Systemic steroid was also
biologically,
going on, and we all got a good sparing effect, steroid sparing effect at the end of 6 months itself.
In 20% of cases, you have written Blau syndrome. What was the other manifestation of Blau syndrome?
Sir, loose stools, distended abdomen at time of presentation was one of the things.
It ocular manifestation.
Ocular manifestation was anterior uveitis, as well as apart from that there was vitritis, mild vitritis at the time of presentation.
Any other manifestation you know?
I can't recall as of now, sir.
Have you seen Blau syndrome?
Sir, when I saw it,
How it was basically diagnosed? Basically by rheumatologist or on your part?
sir, these patients were initially presented to a rheumatologist and then referred to our site to check for uveitis as well.
BSK is one of the commonest presentation.
So follow-up was for 12 months. That is again something which, like this study is still continuing on because we have to collect a more sample size.
No,
And
this data in your slide
Yes,
is
sir.
for follow-up for how many months?
1 year or 12 months.
For all 7 patients?
Yes, all 10 patients.